Okay. Hello, everyone. Thank you for joining us this afternoon for our September AI in Action event, which is titled The Little Clinic That Could, an AI Scribe Adventure Story. We're really excited today to be joined by Dr. Jennifer Cortez and Jean Lehoulier from the North Country Healthcare Clinic in Arizona. I'm just going to go through a few introduction slides, and I'll introduce Jen and Sean and then turn it over to them for their presentation. So just a few housekeeping items before we get started. Please make sure that you're on mute to minimize any interruptions. If you have any questions, please feel free to put them in the chat box, and we'll either let the speakers address them as they go, or we'll have some time for Q&A at the end as well. And then just a note to please disable any external AI note takers. We have a Zoom AI companion running right now, and we'll send out the recording slides and a summary of today's session following the event and post those on our website as well. And if you run into any tech issues, feel free to chat with Wes. Wes can wave his hand. But Wes is an awesome colleague here from the CCI team who can help you if you run into any tech issues. So we'll hand it over to Jen and Sean in a moment here. Jen is a primary care clinician and the Quality and Population Health Medical Officer for North Country Healthcare, which is a community health center with multiple sites across northern Arizona. And Sean is a family nurse practitioner and Deputy Chief CMO for North Country Healthcare's Western region. The two of them lead one of our practice network sites in their AI implementation over the last year. And so we're really excited to hear from them today and for them to have the opportunity to share with you all what they've been working on. So I will turn it over to you, Jen and John.
Great, thanks, Sierra. So we'll go ahead and get started. Our agenda for today, we'll just give you guys a little bit of background on North Country, and then we'll go into a little more detailed description of our Kingman clinic and the Scribe, the AI Scribe pilot that we did there. We'll discuss some of our organizational AI governance development, and then finally finish up with some lesson learned and next steps. So North Country Healthcare is a federally qualified health center serving northern Arizona, focused on providing high quality, comprehensive primary care to all patients, regardless of their ability to pay. We have 13 clinic locations that are spread across the I-40 corridor, essentially, which is primarily medically underserved rural communities. We provide healthcare to about 55,000 unique patients annually, and the services we provide include primary care, FM, internal medicine, peds, OB-GYN. We do mobile and shelter services as well as school-based services. We provide some urgent care services. We have behavioral health, dental, physical therapy, clinical pharmacy, and then also have some community outreach programs and clinical education programs as well. So as an FQHC, we, and probably a lot of other organizations in healthcare these days, we experience some fairly significant resource constraints. And so just to give you an understanding of kind of our starting point with all of this, from a technical perspective, we have poor connectivity at a lot of our sites. Even this morning, Sean was a little concerned about connectivity at the clinic, and he had to go home to make sure it would stay connected for this presentation. Our Wi-Fi is a bit outdated, and we're having to work on updating that. We're on a legacy EHR. Currently, what we use is Athena Practice, used to be GE Centricity. But because it's an older system, there's limited operability and limited opportunities for integrated solutions for different problems. With regards to staffing and the skill set that we had at the start of the project, in general, like a lot of places, we've got recruitment and retention challenges, especially at some of our more rural settings, just at baseline. And then in addition, during this project, we also had significant leadership turnover in key positions specific to AI. So our chief informatics officer and also our compliance officer are positions that turned over the course of this project. We did not have any AI expertise on staff outside of the few of us that kind of dabbled a little bit, with things like ChatGPT and Claude and the like. Prior to getting started, we have a single HIT developer. So that's a person who kind of runs reports for us with regards to data. We don't have a formal data analytics team or data scientists, et cetera. And then also we just have one project manager for the whole organization who's wonderful, but she's just one person. So she tends to help with bigger projects, and we were lucky enough to have her supporting us for this project. From a financial perspective, like most other FQHCs at baseline, we've just got tight margins. So a lot of times if we're trying to pursue something new or innovative, or a service that we're not already providing, or some new tool, we often rely on grants. As everyone on this call has probably experienced, there's a lot of changing with funding streams right now. And so that's really resulted in a lack of clarity for future revenue, and has complicated trying to figure out how to allocate resources. And then, of course, there's just competing needs. We want to move forward on AI projects, and, other areas want to move forward on other pieces. And so just competing needs for our scarce financial resources. And so you might say, gosh, with all these resource constraints, why are you even trying to move forward on this right now? And I think we felt that there actually was a fairly urgent need to start addressing AI tools, and specifically scribing. So it's well known that documentation burden impacts clinician well-being. One of our strategic initiatives is to try to improve the well-being of our clinicians. And so that's always we're always looking for ideas or opportunities where we can make the clinician's life a little easier. In addition, some of our staff were eager adopters of AI Scribe tools, and so we're already using them without any organizational guardrails put in place. Because of our baseline recruitment retention challenges, we did worry that as time goes on and the Scribe tools become more commonplace, that it potentially could worsen those things if we can't figure out how to get some governance in place and be able to adopt tools like this in the near term. And then finally, I think we all recognize that there's a need to prepare the organization for safe and effective adoption of AI tools, as it's likely that use is going to be widespread. And then, in terms of why we thought this was the right time, despite, again, all these challenges we're dealing with, I think it's because we do, despite all of the challenges, we do have some assets, and I think we felt that we had some opportunity around this project. And so the first, and what I think is the most important piece, is that the clinical team works very well with the HIT team already. And so that was something that I think, when we started thinking of the AI scribing tool, it was really easy to bounce ideas back and forth with them, and have support kind of from both teams. In addition, there was a core team that was really, eager to get this tool available to clinicians, and was really excited about learning new skills. We had early clinician adopters of technology. The people who had started using the tool already were willing to help support their colleagues in tool adoption and help us to manage the pilot. And then the use case aligned with our organizational strategic initiative to improve clinician well-being. We also felt that we could leverage a Scribe pilot to develop organizational AI governance. And then finally, we recognized the significant opportunity that had been presented to participate with experts in the field through the Health AI Partnership Practice Network. So Sean, I'll turn it over to you.
Hi, Sean Louier. And as she mentioned, the early clinician adopters, that's me she was talking about. North Country Healthcare in Kingman, Arizona. We are located in Northwest Arizona, about 3.5 hours north of Phoenix, about an hour and a half south of Las Vegas, and 6 hours east of Los Angeles, just to sort of give you a picture where in the Southwest we are. If you've ever driven to Las Vegas on the I-40, you've stopped in Kingman to go to the bathroom and get gas. We have a population of about 35,000 people as of last year. And, that also gives you an idea how far away we are from any tertiary care. Like, we're looking at 2 to 3 hours to transport a patient or refer a patient to the more advanced specialists. So why Kingman as a pilot site? Again, we have eager clinical champions here at our site. We are representative of rural challenges. It's a manageable scale for the pilot. And this is one of our bigger and busier clinics in the organization. We typically see around 1,500 patients a month and are normally between the top 1 and 3 producing clinics in our organization. We have 8 providers on staff, 3 physicians. 1 is IMPs, 1 is internal medicine, the other is family medicine, and we have 5 nurse practitioners. And we see from birth to old age, we treat HIV, hepatitis C, behavioral health on site here. So our pilot experience, clinician engagement, engaged clinic leadership staff and identified early adopters to support. We provided basic AI education to our providers about, how these tools work and how they're going to produce these notes. We developed workflow training, including standardized disclosure processes to our patients. So before we would use the tool in the room, the AI Scribe in the room, we would say, hey, we're going to use this tool. It's going to help us generate a note faster so we can, spend more time engaging with you and not a computer. We administered baseline mini-Z burnout assessments to all of our clinicians before we started the pilot and then midway through the pilot to gauge if, patient provider burnout was improving. Specific tool training provided by vendor during the clinic meeting. So we had our regular monthly clinician meeting. So no time was blocked out of the ordinary, and the vendor was able to do a Zoom presentation just to show us quickly how it worked, and we were able to jump right in that day after our meeting and start using this tool with no additional training, and there was really no ramp up time for our providers. For patient preparation, pre-implementation surveys assessing comfort level with AI Scribe tools. So this was done for a few weeks before we started the pilot, and then we repeated that about, again, midway through to see how the patients felt once, when they were engaged with the AI scribing tool. We had informational handouts created in English and Spanish in all the rooms, so posted in the rooms, and we had handouts available to give to the patients to take home if they wanted, which just very basic description of what AI and AI scribing was. And we developed a standard disclosure process with opportunity for patients to opt out of use of tools. So when we would introduce the patient that, hey, we're going to use this tool, if they said no, they didn't want to participate, we had a dot phrase that said no, and then another dot phrase that said yes, and that allowed our IT folks to track the acceptance rate. Should I answer questions now or later?
Sean, I'll take care of the chat.
Okay. And then Wes, yeah, thank you. So the pilot experience, we've got the good, the surprising, and reality check. For the good, clinicians quickly picked up use of the tool. Again, immediately after the meeting, they were seeing patients using the tool and were surprised at how easy it was to use and really how life-changing, how work-changing this tool was. It was particularly helpful for longer visits. It's a perceived decrease in clinician cognitive load. And really, what we were excited about also was that there were no charts on hold at the end of the month. So we saw a decrease, and we'll show you numbers later, a decrease in the amount of time charts were open from the time they were created to we were able to sign them off. We had a significant decrease. The decrease in the clinician cognitive load is because we're not having to retain that visit information in our brains until we have a time to write it all down. We have less anxiety. We feel confident that the visit note is complete. It just needs to be transferred over to the EHR and signed. The surprising 0 patient refusals to participate in the pilot. The technology adoption was smoother than expected, and that may just be hesitancy on our part from past technology changes that didn't go so well. And there was really no decrease in charts closed during off hours. So, and again, we think that was because the clinicians were more confident that the notes were done, so they didn't have to rush home to work on them right away. The reality check, it doesn't solve tech issues. So it doesn't solve poor connectivity problems. It can't fix the cumbersome EHR or clinic-based workflow challenges. And the illness and vacation during the pilot may have affected some of the data. So we had people out sick and on vacation, so some of our time to close numbers got higher as the pilot went on because they were out and not working. Okay. So pilot outcomes, workflow impact. Like we said, we had 100% patient acceptance of the pilot to participate in the pilot. And you can see here for time to close charts in minutes. So again, this is the time the chart was created when the patient checked in to when the clinician signed it off, whenever. At baseline, we looked back 6 months prior to the pilot at that number, and it took about 300 minutes to close a chart. And at post-implementation, so about a month or 6 weeks in, we looked at it again just for that time frame, and that time had dropped to 187 minutes or 38% improvement. Charts closed during pajama time. So this is anytime the clinic was closed on weekends. We actually saw a 2% increase in charts closed during that pajama time, and also a 2% increase in unsigned charts greater than 24 hours. Our organizational goal is to have charts signed off within 24 hours. And again, the PTO and vacation may have played some role in this, but we saw a 2% increase. And again, I think these two numbers just show the clinician confidence that the note was done and just needed to be transferred over and signed off. And we also saw about a 5% coding complexity capture. So as the AI tool listened to the conversation, it caught more details that we may not have remembered or charted. And when we reviewed it, we saw, oh, well, this is really more complex than I was going to bill for, so we can, bill for this more complex visit. The clinician surveys and
I'll take over here, Sean.
Oh, yeah, sure.
Yeah, and go into the clinician surveys. So this is where I think we felt we were able to see the biggest impact from the use of the Scribe tool. We had the clinicians take a mini-Z burnout assessment prior to starting the pilot and then at the end of the pilot. We did see major improvements, which were greater than 30% change in a few areas. Control over workload increased by 32%, decrease of EMR frustration by about 39%. Sufficient time for documentation went up by about 60%, and time spent documenting at home went down by about 62%. And so I think just to kind of emphasize information on the last slide where it talked about there was still a lot of charts being signed at home, we weren't really able to capture how much time the clinicians were actually spending on those charts at home. So even though it didn't really seem to impact the number they were signing off on, it's very likely it just was taking them less time to do that based on these results. And then overall, in the area where we did expect to see the most impact, which is the work pace and EMR stress, we did see a 40% improvement in those values. And then supportive environment, which is more outside, I think, of an area where we would think there would be impact. The improvement was less, 7%, but there was still some improvement. Sean, do you want to talk about the patient surveys?
So the patient survey, so when we surveyed the patients about their willingness to use AI, how familiar were they with AI and how comfortable they would be with it, we had really good scores at baseline. Our clinicians had really high scores. It's a 1 to 5 grading system. And, you know, at baseline, we had my clinicians spent most of their time looking at me, 4.29%. So at post survey, we saw a 1% improvement. So it got better. And you can see, we really wanted to highlight during our future visit, I'd feel comfortable if my clinician used AI to take notes. And we saw a 20% improvement or you know, potential acceptance. So we were kind of surprised by these numbers. Mojave County, rural Northwest Arizona, there is a lot of distrust of the government and technology. And we really thought we'd have a lot more pushback. This would be a more difficult acceptance. And like I said, we were happily surprised. People were willing to do this.
And then just to touch on some of the work we did regarding policy as we were working on the pilot, definitely want to give a shout out to Health AI Partnership, who provided a lot of critical guidance and support for us as we went through this process. But simultaneously, as we're kind of working through all the pilot pieces, we were trying to develop some governance. So we restructured our HIT steering committee to include AI oversight. We created an AI use policy, which finally just got approved and posted like a week ago. So that was exciting. We also developed a software adoption policy that addresses AI tools, which has also been approved. And as part of that, we created this smart sheet form so that staff members could request and to help us track requests and approvals, et cetera. And then we did one of, I think, the key pieces that helped us with the procurement phase of the pilot was developing this AI vendor assessment tool. I say developing, I should probably say adapting from, you know, shared tools from Health AI Partnership as well as California Telehealth Resource Center to develop our own AI vendor assessment tool that helped us kind of focus a little bit more on some of the aspects that I don't think we were thinking about to the same degree with regards to data storage and management and privacy, et cetera. And then finally, we also developed an intranet resource page for all staff. That has not come out yet, but it's ready to go. So hopefully any day. And then key drivers of success. I think for us, we felt that really collaboration was the most important element of being successful with this effort. As we've mentioned before, our internal partnerships with HIT and clinical teams really made it easier to get through the workflow design and integration process, the change management, you know, trying to measure outcomes. Sometimes they don't turn out how you want or how you expect them to. And so you have to make adjustments and understand how to interpret your outcomes. And so it was really helpful to have a good working relationship as we approach this study. And then, of course, working together on governance. And so, and then, of course, the external partnership support that we received through Health AI Partnership, in particular, the key decision points framework, the vendor assessment tools, mentorship and guidance from the different support groups that provided additional information on sort of like the community experience and regulatory issues, et cetera. And then also just best practice sharing with other members of the practice network.
So some clinical lessons learned. The most hesitant clinicians at the start have fully embraced using AI scribing. One of the physicians was worried his accent would limit his ability to use the tool. He had had issues with Dragon in times past. He was immediately impressed with how accurate the transcription was. Another physician was concerned that her unique style of charting would be too difficult to use with the copy and paste method of the AI tool. She was excited when she realized she could train it to match her style. It was soon learned that the tool captured and documented more information than we personally did without the tool. We were able to increase the complexity of the visits and accordingly the billing in early data. Again, we're still only 12 weeks maybe into the pilot, so we haven't got all the data on billing. The relief knowing that if we weren't able to finish all of our charting at the end of the day, the notes were completed and would be available to add to the chart later or the next day. And patients commented that they appreciated more face-to-face time with the provider, as we weren't spending all of our time looking, at a laptop screen. That the patients actually felt we were more engaged.
Of course, I'm muted. From an organizational perspective, lessons learned. Really, I think the Scribe pilot, we started looking at sort of like a smaller piece of things, but it really helped us to discuss at a higher level broader digital transformation, and this focus on really needing to improve our existing infrastructure. And so I think it's helpful not only just moving forward with technology, but also just highlighting the importance of bringing our systems up to date and making sure things are working efficiently so that over time we can leverage these tools more easily. Another lessons we've learned is that making the financial case to scale a successful pilot, because we did feel that this was a successful pilot, even when it aligns with strategic initiatives, is really challenging. We weren't really able to demonstrate, that hard return on investment, like, oh, now our clinicians are seeing a whole lot of extra patients, or, what Sean was talking about, coding complexity. There's a little bit of that, but it's really too early for us to know how that's going to pan out. And so for our chief financial officer, while I think there's this hope and our leadership is supportive of the use of the tool, and there's this hope that long-term it's going to help support recruitment, retention, and be cost savings because of that, because it doesn't really generate revenue. It's just hard when finances are tight to be able to scale organization-wide. And then again, with the lack of predictability and funding due to changes at a national level, just make this all the more difficult. I think a lot of us are concerned about the impact of some of the changes affecting Medicaid are going to have on us that go in effect next year. And so it's just really challenging to advocate for investment in something novel right now because of some of those financial challenges. So I think for our organization, the jury is still out as to whether or not we'll be able to scale or when we'll be able to scale. But our team, I know, feels like regardless of what happens, we do feel like this was successful. The pilot was successful. And even more importantly, we were able to develop an improvement in organizational literacy, develop internal AI governance structure, and create a solid foundation off of which we can build in the future. So I think regardless of what happens with the pilot, we've positioned ourselves well to be more successful over time.
Jen, I thought you were doing this one. I was going to be
next. sorry, for next steps, we are still working, like I mentioned, on identifying a financially feasible way to scale the Scribe tool to remaining clinics. We're in the process of improving our internal Wi-Fi, which will hopefully help with some of the connectivity. The connectivity is a little bit complicated because some of that is external to our organization and a little bit harder to control. But we're hoping that the improvements we make will help across the organization. We're continuing to work on trying to plan a transition to a more modernized EHR. An additional issue that we identified while we were working through this project was data governance challenges, and just that we probably need to get our hands around that a little bit better. So that's another thing we'll be working on. Trying to figure out a sustainable funding model for technology innovation moving forward, I think, is another thing we'll try to address. And then one of the last pieces, this is probably true of a lot of FQHCs, but we have patient advisory committees. And so the patients at each clinic site will help us make decisions about how to provide care that aligns with their needs and desires. And so I think while we do have support from our board, which includes patients as well, we'd like to get better engagement of those patient advisory committees to help with these types of projects more in the future.
So some recommendations. Perfect is the enemy of good. Just get started somewhere. You know, we were worried how we were going to get to this place where we are now, and Dr. Cortez and I and our team just jumped in, and we found HAIP, and away we went. A key requirement is strong internal partnerships with HIT, clinical, and other teams. Start small. Like, you know, we had a small pilot for a reason, so we could better manage who was using it and the data and everything. Build the governance as you go, because, you know, we obviously didn't know what we didn't know when we started. And as we got into this and learned more, we realized what guardrails we needed to try to develop. Keep focus centered on your patients and human capital. Measure outcomes to help make your case, right? The money handlers, the CFOs are going to want to hear hard numbers, not just, I feel better using it. They want to see that, you know, we were able to see more patients, or that we were able to, you know, make cases that our cash flow would improve. Leverage external resources and partnerships. Like, you know, we keep mentioning the HAIP folks. There are groups out there that can help, and, you know the things, have been where you need to go and can help you, guide you.
And then key takeaways, just for anyone that's similar to us, I think our 2 cents is that resource constraints are not barriers to innovation. They can force creativity and collaborations. Collaboration and partnerships are really the force multipliers for under-resourced organizations like ours. And so definitely seeking those out is important. AI implementation and safety net settings is possible with the right approach, and governance development can happen alongside implementation. We also wanted to emphasize that the patient and clinician experience need to drive these decisions about technology, just to make sure the technology continues to serve people. And that's it. So special thanks to all of you for coming to listen to us. And then also the Kingman Clinic staff and patients, our North Country leadership, and of course, Healthy Eye Partnership. And I couldn't keep up with the questions after a little while. I'm happy to start going through some of them here. If you guys want, I'm not sure how you want me to do the questions.
Yeah, I'm happy to kind of read through and go through some of the ones that you didn't have a chance to address in the chat. So I guess I'm taking a look at some of the questions that have been dropped, and I'll read some out to you both. So, do you have an estimate on how many patients your providers tended to see per day? And did you see an increase in the number of patients that your providers were seeing with the use of the AI Scribe tool?
Yeah. Our organizational goal, we have different targets. So a baseline, we're looking to see 2 patients an hour, and then up to 3 patients an hour. Our clinicians here, depending if they're on an 8 or a 10-hour day, are averaging between, like the 10-hour day folks are averaging around 18 patients a day. I'm sorry, the 10-hour a day folks are averaging around 23 patients a day, and the 8-hour a day folks about 18. And then we have some newer clinicians on staff, so they're at a reduced panel as they ramp up. But that's about what we're looking at.
But we did not see an increase in volumes. And really, we didn't design the project where we thought there would be an increase in volumes. The clinician templates really stayed the same. Clinicians did express that they felt they would be able to see more patients, but during the study period, we didn't see that pan out.
Awesome. I think that's in line with a lot of what we've seen from other organizations at this point as well. Another big question that I think folks always have is kind of the ROI and the value on investment that you're seeing with this. Would you be able to speak to kind of like any implementation costs versus savings, both kind of that you were expecting to see, and also things that you noticed throughout this pilot process that were unexpected?
So we were very fortunate from a cost perspective that the vendors have allowed us to trial their product, without necessarily purchasing it. So in terms of upfront costs, there really weren't any outside of the time and effort from the pilot team. Even for the clinical staff, when we rolled this out, we rolled it out during a standing clinical staff meeting. We didn't alter patient schedules or anything. And I think it actually worked that way. It went just fine. And so I don't think there was a lot of upfront investment from that perspective outside of all the groundwork we did. But I feel like I lost my train of thought here. The one thing that I wanted to say is ROI. Ask your vendors, if you're talking to people, if they have an ROI tool. This is definitely something we learned during the project. A lot of them will have like a spreadsheet that they'll share with you and be like, plug in these numbers, that reflect what's going on in your clinic. And they'll help you estimate the ROI and share that with your leadership. And so definitely recommend doing something like that, asking people if they have that and if they would share it with you. Because I think it helps make the case. The problem we still had at the end of the day, though, is because we didn't see an increase in volumes and the complexity data is a little hard to interpret and not entirely clear quite yet, we really weren't able to demonstrate hard ROI. Our main takeaway was the improvement in the clinician well-being aspects of the burnout survey.
Which I know is a big metric that you went into this process looking
Yes.
to try and address.
Yeah.
I think on a similar note, you kind of shared at the beginning that you all are on a somewhat unique EHR. I think you're on the legacy version of Athena. Can you share whether that influenced your selection of AI Scribe tools and the process of kind of piloting these tools?
No, not really. When we say a legacy version of Athena practice, the system we used was previously, and you mentioned it, centricity. And there's no. I know some newer EHRs have an integrated AI Scribe, and we don't have that option. We're not going to have that option, it doesn't seem. So what we do is we either record the conversation on our personal cell phones or on our laptops, and then cut and paste the completed note into the EHR, which really doesn't take that much time. It's pretty quickly done. And if you haven't used it, by the time you walk out of the exam room and you get back to your office, the note is usually completed. So it's ready to review and move over.
And I just add two comments real quick. One is when we started this process, we thought we were going to be already moving on our new EHR. And so we actually did look for tools that would have been integrated into the new EHR. But as the AI Scribe scene, if you will, is changing so rapidly, and we are so slow to move on our EHR, it feels. I think in hindsight, we probably wouldn't have worried about the integration aspect of it, like just get something up and running and move forward. And then when we're on an EHR where it could be integrated, we would do it at that time. And so I think if you're at a facility where you do have options for an integrated tool, I think that's definitely preferred. Like we would love to be able to look at that over time. I would anticipate there's like more time savings and a lot of other benefits to it. But I think we just wanted to get something up and running, especially since we knew clinicians were already using tools and we wanted to kind of get our hands around it.
Awesome. Okay, so my next question is going to take us a little bit into kind of the governance and just capacity building work that you all were working on. So, given kind of the resource constraints that you had in terms of not only resources, but also different types of expertise within the organization, how did you go about kind of building out a governance system that accounts for those limitations and still allows you to build kind of a robust system?
Yeah, that's a great question, and that has been challenging. And I think I may have seen this question, and they were talking about like ethics, and is that the one you're mentioning, Sarah? Yeah, because I do think we definitely don't have we're never going to have like a dedicated ethics person. We're all doing the best we can and working with sort of our compliance counterparts and regulatory counterparts and patients to provide us with feedback in some of those areas. But I think we just did the best that we could to try to learn. We relied on our external partners. I will say that we are not adopting like clinical decision support tools or like predictive models because we don't really have capability within our system to monitor, maintain those, et cetera. So we're really talking just about Gen AI right now. I think, and there's other questions along here that kind of get to this as well, but like, I don't think we'll be able to do that without either support from the EHR or support from local partners, just because we don't have that capacity and it's unlikely we'd be able to pay someone that has that skill set to provide those services for us, at least in the near term. And so I think really working on trying to figure out where we might be able to collaborate with local universities or I think someone put in here, hospitals and that type of thing. I think those are things we're trying to work through right now because we are limited. We need either to be able to rely on the vendor to help us troubleshoot problems, which probably is good with whatever tool anyone adopts. But, we definitely need to make sure we have a responsible vendor that's going to help us troubleshoot. And then again, like truly assessing these tools before we would approve any of them to make sure we can not only implement them, but be confident in the data that they're using to make any kinds of decisions, and then have the ability to monitor that data over time.
I think you make a great point about the difference between kind of the considerations that you have for a Gen AI use case versus the clinical decision support use case and the different pieces that you have to think through in those implementations. Let's see. Okay, looking at kind of the pilot itself, what areas of improvement, if any, would your clinician team have for the tool? And is there a possibility to assess the notes generated in order to assess patient satisfaction? I think you have done that a little bit with the survey, if you wanted to speak more to that.
Yeah, so, we just had a meeting this morning where we talked about like a workshop on what works and what doesn't. And we've tried two different tools. I don't know if we can say what tools we've used, but comparing them side to side, everyone liked one tool or the other or had no opinion. They both worked fine. The common agreement was no matter what happens, we are going to continue. We want to continue using these tools to help generate our notes. but really, nitty gritty, it's things like one tool organized things a way a clinician liked better than the other tool did, or one tool did a better assessment and plan than the other tool did. So, and then, it's on the clinician to review the note that's generated to make sure that it's accurate, that the AI didn't hallucinate or add things that weren't there, pick up on stray conversation, and correct it if needed. The tools do seem to learn. So as you make corrections, it tends to learn your style, and we'll bring that up as you go, make more notes.
Thank you, Jen. And Jen, anything you wanted to
add? Sorry, now I'm like scrolling through the chat, so I'm going to leave that one to Sean.
Okay. Let's see. I see a couple of questions from Elkin as well. He said that it was wonderful that part of the pilot included collecting metrics of success, like kind of that 6-month look back, clinician burnout, et cetera. Can you share reflections that came kind of from your leadership based on the data and insights from the pilot? How are they kind of thinking about the implementation of these tools, both now and in the future?
I presented, I gave a presentation to the senior leadership at the midpoint of the pilot, and surprisingly, I was really surprised at how supportive all the executives were. Like from the CFO on down, who I thought would just say no right out of the hat. They all expressed support, and they want to find a way to make this work for us, for the organization.
Yeah, I would agree. I think our leadership has been supportive for sure. I think at the end of the day, though, it comes down to the finances, which is just really hard because, we're talking about this one AI Scribe tool, but then that takes funds away from our infrastructure improvements, or our EHR transition, or other projects here or there. And so it's trying to just figure out priorities. And so that piece at the end of the day is still a challenge for us, but I agree with Sean that I think our leadership is supportive. For some of these other aspects of the question that Elkin has, I do think that it was helpful for us to present data in this way to our senior leadership. I don't know that that's something our organization has done historically very well. And so I really do think that it's made a big difference. And then moving forward, I think it sets a higher bar for how we make decisions on different projects.
Okay, I think we have time for 1 or 2 more questions before I hand it back to the CCI team. So feel free to add any last ones you have in the chat. I guess this one is kind of an amalgamation of 2 questions, but could you elaborate more on kind of how you approach the process of selecting a vendor? What were you looking for? What was important to you all? And how did you kind of negotiate your relationship in terms of data sharing and things along those lines?
I'd like to give some history to that. Is that Jen and I were in a meeting 2 years ago, maybe, and we both realized we had been using AI for different things. And so that started this ball rolling, where we formed this group to create this pilot. And then we looked at just, on their websites or from personal experience, what tools we've used personally and what we liked and what we saw online and found through Google searches. And we got hooked up with y'all, Sierra, and got more recommendations, and then our team reached out, and Dr. Cortez is better at those details.
Well, Sean, the clinicians there at that clinic already had some tools that they were using. I think I mentioned this already, but we were really looking at ones that were going to be in the EHR we thought we were transitioning to at the time. And so that was Epic, and I know they actually list what tools they integrate with, et cetera. And so that's kind of where we narrowed it down. And again, I think in hindsight for us, we probably would have had a broader search had we just realized we were going to end up doing copy and pasting, which is fine for right now too. And so I think that's one thing I would mention in terms of tools. the Alien briefing is amazing if anybody's not been using those. And they actually had a really good presentation on AI Scribe tools. But they'll give reviews and they have, I think, a Scribe comparison chart and that type of thing, which we used as well to try to kind of narrow those down. And I think big picture, we tried to identify a partner that we thought was one would complete our vendor assessment tool and that we felt comfortable with the responses they provided regarding data management and storage and security and secondary use of data, et cetera. So that was something I think we definitely looked at. And then what did I say? So the vendor assessment tool and trying to figure out if they seem like they're going to continue in this space. So I think over time it's possible there's less AI Scribe tools as they become kind of integrated into different EHRs. And so just making sure you're choosing a tool that seems like they're continuing to be forward-looking in this area, and that they'll be here like a year from now or something like that.
Well, I think that is all the time we have for questions today. Thank you so much, Jen and Sean, for coming to share. We at HAP have learned so much from you all over the last year, and I'm excited for you all to have been able to share this with our community as well. So thank you so much, and I'll turn it back to the CCI team.
Thanks for having us.
Yeah, thank you.
Great. Thank you so much, Sierra. Thank you, Jennifer and Sean. I'm going to wind us down here as we approach the top of the hour. With a few reminders, I'll also share in chat here. So just be sure to save the dates. But firstly, thank you all once again for attending. Thank you, Jen and Sean and your colleagues there at the Kingman Clinic for sharing some of the insights today. Please complete the survey link that I just dropped in the chat to let us know how any ideas you might want to see for upcoming AI in Action webinars. This is a monthly series. We'll be picking back up in October, featuring the California Healthcare Foundation and Culture IQ. You can share the registration link there in the chat as well. And that session will focus on what patients think about AI in healthcare as they kind of reveal and share insights from the focus groups. Also, just wanted to share about our upcoming Safety Net Innovation Summit entitled Wayfinders, Community Innovation for Uncharted Times. For those who are thinking about or are in the Berkeley area here in the Bay on October 8th and 9th, the summit will offer a space to explore how to turn moments of chaos into catalysts for partnership. So we're going to equip you with tools to stay resilient, adaptable, and just really ready for the unexpected. You can expect expert-led discussions, interactive workshops, real-world case studies to provide you with insights that you can use to traverse systems of transformation and also advance health equity. Newly announced is that tickets are now $200. So we did that because we want to ensure that we have as many leaders and community innovators such as yourselves in the room. A workshop feature that I'll spotlight for you all now, this is the audience for that, is Smart Steps for Safer AI Adoption. So choosing the right AI solution, as we learned today, isn't just about the features, it's about trust, transparency, and also accountability. So you'll get in this session concrete steps, peer tested insights like you got today, and a chance to shape new tools that will put the safety net in the driver's seat. So I'll share the link to register that. It's only now $200 on October 8th and 9th. Please complete the survey. This is what I was talking about. It's now $200. And again, thank you to Jen and Sean, Sierra with the HAIP team. And I'll keep the line open for the last 5 minutes so folks can get a hold of the links that I'll drop or have dropped in chat. But thank you again for the time and feel free to drop off as needed.